Thank you, sir. May I now invite Dr. Srinivas Samavedam again for the concluding talk of this session. Yeah, mechanical power versus driving pressure. What is the best ally in lung protection? Over to you, Dr. Samavedam.
Good morning again. Driving pressure or mechanical power, which is your best ally in lung protection? You can't say which one. End of the day, you have to pick and choose. Let's see whether we can make some consensus at the end of the discussion. What is the concept of driving pressure? I've always been fascinated by the blowing the balloon concept while talking about mechanical ventilation, and I will extend that to the driving pressure as well. So all of us who have blown balloons will know that when you start blowing the balloon, the work you have to do is a little higher. Once the balloon starts expanding and it reaches a particular shape and size, your job becomes easier. So the amount of work or the amount of pressure you are actually delivering to the balloon for it to reach an optimum size is the driving pressure. And the pressure where it stays at that particular point of time is your plateau pressure. And when you release the balloon, you know that it does not come back to its original shape, what it was when you took it out from the packet, right? It has some amount of residual volume that generates some pressure within the walls of that collapsed balloon as well. That is PEEP. So if you can look at this concept and then extrapolate it into your mechanical ventilation, above functional residual capacity, the amount of work at tidal exhalation to peak inspiration, what you do is the pressure that is required to reach that top level of alveolar efficiency is driving pressure. So what is the relationship of driving pressure to the routine work we do in the intensive care unit? So if you look at the beach volleyball and try to inflate it to approximately 500 centimeter, 500 ml of tidal volume, average in a good compliance system, you have probably got to distend about 20 centimeters of 25 centimeters of pressure to get the ball to expand. But if you try to do that, if you try to do that, we apply the same 25 centimeters pressure to a basketball, you will end up getting lesser tidal volumes. So if you look at your normal alveolus as the beach volleyball and you look at your ARDS alveolus as the basketball, you know that at lower tidal, if you want to keep the pressure constant, you probably have to deal with lower tidal volumes. So that is the analogy of these two pictures. If your beach volleyball is a pristine lung like that, and then your ARDS lung is the basketball. So as the lung becomes stiffer, if I want to get the same amount of tidal volumes into the lung, my driving pressure increases. So if you flip the statement on its head, you could say that if the lung compliance is worsening, your driving pressure is rising. So it's a very simple analogy. Now that's not so simple. You will have lungs with different levels of collapse and different levels of alveoli. So if you look at a lung that does not have too much of collapse, does not have too much of fluid, and PEEP is optimum, you increase the pressure in the lung, it does not overexpand, it reaches a particular point. So if you have somebody who's getting 500 mils of tidal volume with a compliance of about 50, the driving pressure to reach end inspiration is only 10 centimeters of water. This is what a stress index of about 1 would mean. So at a normal compliance, not very great driving pressures and no hyperinflation in the lungs. But if you have a lung that is restricted in its expansion because of consolidation or ARDS, what would happen is for the same, if you keep the tidal volume constant and this lung, which has got multiple areas of atelectasis, would have a compliance that is 50% of the lung you saw on the earlier picture. So the driving pressure to reach that 500 mils of tidal volume is about 20 centimeters of water, but that results in hyperinflation. You can actually see these are the these are the alveoli which are hyperinflated. These are the normal ones. and the stress index is more than 1. So the driving pressure is an index of how much hyperinflation actually your lungs are facing. Similarly, if you reduce the tidal volume, what happens to the driving pressure? Obviously, the driving pressure comes down for the same compliance, and you will see that the hyperinflation has disappeared. So, in subjects in whom your ventilatory strategy is probably resulting in hyperinflation, a monitoring of driving pressure and bringing it down could result in achieving a ventilation without the risk of hyperinflation, which is the major concern when we are subjecting patients with poor lungs to uh, positive pressure ventilation. So if you keep the tidal volume constant, or if you keep the driving pressure constant, the tidal volumes constant to already hyperinflated lungs, what happens? So you can see that if you reduce the driving pressure in lungs which are already hyperinflated, if you reduce the driving pressure or you deliver lesser driving pressure to the lungs, the stress index reduces, the degree of hyperinflation reduces, and more amount of expansion happens to the lung. Similarly, if you look at a lung which does not have hyperinflation, which is normally ventilating, a decrease in driving pressure improves the mechanical advantage. But if you have set very high PEEP to the lung and a portion of the lung is already hyperinflated, if you deliver a higher driving pressure to the lung, your hyperinflation increases. So to limit the amount of hyperinflation, to allow adequate ventilation, you probably have to target your driving pressure in most patients on mechanical ventilation. So how do you put it into an algorithm, right? So if you have a patient who's being ventilated with 6 to 8 mils of body weight tidal volumes, you measure the driving pressure. If your driving pressure is less than 15 centimeters of water, you'll be happy with that. But keep monitoring it. Don't stop monitoring it because ARDS is a dynamic phenomena. But if your driving pressure is more than 15 centimeters of water, it is probably a decreased compliant system. So you see whether this is ARDS or other restrictive lung diseases, and you use maneuvers to reduce your driving pressure to less than 15 centimeters of water. Now, this logic applies when you prone your patients, right? While it is agreed that long proning durations are recommended, multiple episodes of proning are recommended, but once your PaO2s, PCO2s notwithstanding, if a patient does not drop his driving pressure when you prone him, such patients are more likely to fail prone ventilation, and rather than waste more time in proning them, you should consider extracorporeal support in such patients who don't drop their driving pressures once you have done a couple of hours or 4 hours of prone ventilation. So the refinement to this algorithm is this one. So you set the mechanical ventilation and you monitor the driving pressure. The driving pressure increases from baseline or is more than 14. You look at morbid obesity, intra-abdominal hypertension. If none of them are there and the plateau is more than 30, you intervene to reduce the driving pressure. How do you reduce it? By applying transpulmonary pressure. So a patient who's not actually responding to your driving pressure, before you take the next step of subjecting them to extracorporeal support, you try seeing transpulmonary pressure, which is actually the lung pressure. So keep your transpulmonary pressure below 12. I think you will be happier. And even if the driving pressure is high, at a lower transpulmonary pressure, the 3 or 4 difference in between transpulmonary and driving pressure is something probably which an edematous chest wall is taking for expansion. So that's the combination of driving pressure and transpulmonary pressure. Now, this is all static phenomena. When I say driving pressure, we are looking at one point of time in the lung. It is not a dynamic entity, but respiration, whether it is positive or it's negative pressure breathing, is a dynamic phenomena. The lung expands and relaxes several times a minute, and as your oxygen requirement increases or oxygen drive increases, the respiratory rates go up. And we believed that during COVID, the so-called patient self-induced lung injury was as much a result of higher tidal volumes as much as it was related to higher respiratory rates. So one of the most neglected components of mechanical ventilation so far has been our interest in respiratory rates, to the point that our hypercapnic ARDS patients were ventilated with respiratory rates of up to 35, because the ARDSnet said if the CO2 is up, you could go up to 35. Is that really good? So because this expansion and relaxation of the lung is happening several times a minute, potential energy and kinetic energy are changing, and energy cannot be lost. And that energy is dissipated to the lungs, which are expanding and collapsing. And that is mechanical power. So power is the energy per cycle times the respiratory rate. Higher the respiratory rate, more times the energy is dissipated to the expanding and collapsing lung. So the relevant component of power is the product of driving pressure and minute ventilation. And compared to the previously cumbersome and mind-boggling formula we had for mechanical power, we now have an easy way of calculating mechanical power called the driving power using minute ventilation and respiratory rate. So higher the respiratory rate, higher the power or mechanical power that is dissipated to the lungs. And this power works both during the elastic phase of the respiratory cycle as well as during the resistive phase of the respiratory cycle. So you have elastic work and resistive work. So the total power, elastic power and resistive power together using the simpler formula can be summated and say total mechanical power of the ventilated lung. So let us look at the relationship between our conventional philosophy of setting tidal volumes based on predictive body weight versus setting tidal volumes based on driving pressure and their correlation with the mechanical power. If you look at this violin plot, the green one is the one that is where the tidal volumes are set based on the predicted body weight or the ideal body weight of the individual. The green violin plot is plotted using the driving pressure. So if you look at the mechanical power, by using the conventional predicted body weight tidal volumes, more energy is dissipated to the lungs. Similarly, if you look at the delta pressure, if you set the tidal volumes based on delta pressure, in patients in whom the mechanical power decreases, along with an improvement in driving pressure, you can achieve better ventilation for these patients at higher tidal volumes. Similarly, if you look at compare this with those patients who are set with a predicted body weight, in those patients in whom the mechanical power actually increases, the amount of tidal volumes will be much lesser, and these patients will have greater ergo trauma when compared to the lungs which are set based on driving pressure. So let us look at the direct correlation between mechanical power versus respiratory rate. We always spoke about our hypercapnic ARDS patients who needed higher respiratory rates. So we cannot have one prescription for all these patients with hypercapnic situation with ARDS. So if you set your tidal volumes based on a driving pressure, the amount of mechanical power that is generated is less, and you can achieve higher respiratory rates and higher tidal volumes, or you can actually achieve higher tidal volumes at a lower respiratory rate. So I have a patient whose driving pressure is 12 centimeters of water. With that 12 centimeters of water, if my if my mechanical power is less, I can actually increase the tidal volume and reduce the respiratory rate in an effort to maintain the minute ventilation, instead of increasing the respiratory rate, which actually dissipates more energy to the lung. So if you combine everything, you combine your driving pressure, you combine your plateau pressures, you combine your mechanical power. So currently a PEEP of 5 to 14 centimeters of water with a driving pressure of less than 15 centimeters of water and a plateau pressure of less than 25 centimeters of water and a mechanical power of 17 joules per minute, less than 17 joules per minute seems to be the best combination of parameters to prevent the ventilator-induced lung injury, whether it is barotrauma, whether it is atelectotrauma, or volutrauma, or ergotrauma. So let us look at this lift concept. If I have to bring a lift from zero or basement, that is FRC, up to third floor, the one big go, I have to dissipate 98 kilojoules of energy. But if I have to bring that lift from second floor to the third floor, I need only to generate 49 kilojoules of energy. And the number of times the lift goes up and down is the amount of total energy that you are consuming. So remember that when you're talking about correlating respiratory rate to mechanical power, and that is the core concept of mechanical power integrated into a combination of driving pressure, transpulmonary pressure, and plateau pressure. So in the end, who is the best ally? Driving pressure is a constant warning sign. So never stop monitoring your driving pressures at any cost. Mechanical power is an added additional burden on mechanical ventilation. In non-hypercapnic patients with ARDS, the delta pressure, the driving pressure is a reliable tool for setting the PEEP. But in who are patients who are hypercapnic, your tidal volumes, your respiratory rates, and your therefore your minute ventilation has to be titrated probably in a better way with mechanical power calculation and assessment. Some ventilators are actually showing mechanical power currently on the screens. So mechanical power plus driving pressure helps in setting personalized tidal volumes and minute ventilation without the fear of ventilator induced lung injury. And this is what machine learning and data science is going to bring into mechanical ventilation in near future. Thank you very much for your attention.
Thank you, Dr. Samvedam, for driving the message very lucidly. May I now invite Dr. Suresh and Dr. Vijay Kumar to come onto the podium for any questions from the audience. As we are running late, we'll just give about a few minutes before we proceed to the next session. Any questions? The resuscitation, the artificial intelligence, the driving pressures, and the phenotypic ARDS. Do you want to ask? Presentations are very lucid, so there are no questions. Yeah, madam.
I can't keep quiet when it is ARDS. So I was just thinking whether we should always go for the pressure control first in the moderate and severe, because all these things will come in handy. That's what I have done for years. And I found you don't have to go to PRVC to that. Rather than go, if it is moderate or a severe ARDS, pressure control ventilation is the first one, so that you can easily manage all these pressures and keep the driving pressure at a lower rate. So that is the usual way. What do you say, Samvedam?
So by choosing pressure control, you are obviously deciding that I am going to control my driving pressure. So you don't need to actually monitor your driving pressures once you choose a pressure control mode of ventilation. But the respiratory rate is independent of the pressure control or volume control, and current understanding seems to be that it also is a major determinant for the systemic inflammatory response which positive pressure ventilation produces in the body. So to regulate that, I think if you put a patient on pressure control, obviously your inverse ratio ventilation becomes easier. But if you have a hypercapnic patient on pressure control, a combination of pressure control with mechanical power monitoring may be helping you with the advantages which pressure control is already giving you.
No more questions. We'll conclude the session.